So let's start with step one, right? All journeys start with step one. So let's go for that. Confirm the diagnosis. Confirm doesn't mean make the diagnosis. Confirm also means proactively excluding the diagnosis if it's not deserved. So let's remember, ADHD in adults is common. It's about 4% in the population. In clinical patients, it's much more. Let's use the DSM to guide us. So here we go. Can we do this? So again, as I said to you, these are pretty busy slides, and you probably will want to review them again. So please don't worry about it. I'll make sure to share them with you. But these are the DSM-5 criteria for ADHD. Well, can I show it to you? And then we'll talk about how many a patient must have. So these are the 9 inattentive symptoms, all the way from failure to give close attention to details to avoiding tasks that require sustained mental effort and everything in the middle. Not one of them by itself makes a diagnosis of ADHD. All of us online today, what is it, 250, 260 some people today? We've all had some of these symptoms on occasion. So what makes a diagnosis different than just having a symptom? And it's this: the person must have at least 6 out of 9 if they are under 17, or 5 out of 9 if they're 17 or older. They must be present for 6 months or longer. And they must start, not diagnosed, but start before the age of 12. So DSM is not designed to overdiagnose adult ADHD. It is not. It is actually designed to accurately diagnose, and actually it's kind of hard to meet the threshold. So if you are relatively new to the world of adult ADHD and you're afraid, oh my gosh, I might overdiagnose patients. Well, if you follow DSM, if you and I both follow DSM to the letter, the risk of overdiagnosis is actually dramatically reduced. Now, this is one side of the coin. The other side of the coin, of course, is hyperactivity and inattentiveness. Let's look at those symptoms. Fidgetiness, leaving the seat in the classroom, having difficulty playing quietly, having difficulty awaiting your turn, all of those. The problem is that this sounds like childhood symptoms, doesn't it? And you'd be right. DSM-5 has not done a great job, it hasn't, making these symptoms much more sensitive to adults. But we will find ways around that. And the same thing applies here. 6 out of 9 must be present if you are under 17, at least 5 out of 9 if you're 17 or older, at least for 6 months. And these symptoms must have started before the age of, remember what age that was? Yes, 12 or younger. Caution. Caution. Throughout my presentation, I will try and offer you pearls of wisdom that we can share together, but I will also offer you cautions. These are mistakes I have made, and you don't want to make them either. Number one, adults with ADHD do not report textbook symptoms often. They don't. We have to elicit it. So the DSM diagnostic criteria were actually primarily developed with children in mind, adolescents in mind. So we will have to do a little bit extra beyond DSM in order to learn the adult presentation. So playing quietly, how does that apply to a 40-year-old? Well, a 40-year-old is not typically playing. So how do I try and explain that? So I have to use adult language. I have to say things such as, well, when you're trying to do things, do you often talk when you're not supposed to? Or do you find yourself jiggling your foot? Do you find yourself interrupting a great deal? I have to kind of slightly adjust the DSM items to perhaps fit what would be adult specific. So caution, adults do not always report textbook symptoms. And on top of that, please look at the second bullet point. And this is why I did want to have this conversation with you. So when Satu wrote to me, I think about 2-3 months ago and said, Will I be happy to talk to my Nordic colleagues? I said, absolutely. There are things we can teach each other that would be helpful. And this second bullet point, my dear colleagues, is extremely important. Patients often don't report ADHD specific symptoms initially. They actually report anxiety. They actually report depressed mood. They actually often come in with marital problems or occupational problems or insomnia problems. That's the entry often of a patient with ADHD into our offices. So textbook symptoms, textbook presentations are not common. That's why this conversation we're having is so important. Do you look on the right, please? Looks like overlapping bubbles. And this is the trouble with ADHD. That is the trouble. Adult ADHD comorbidities complicate things. But having said that, let's be aware all of these overlapping symptoms really can be adult ADHD. So at least half, sometimes in some studies, actually 80% of patients who have adult ADHD have a comorbidity. What kind of comorbidity? And I think there are classic 4 comorbidities: major depression, anxiety disorders, impulse control disorders, and substance misuse. And those are the reasons they come see us. And underneath, I just want to confirm that with you: substance, mood disorders, bipolar disorder, anxiety disorders. And this is often the entry. This is how they self-identify and come into our offices. They often don't even quite know that there is another challenge. That's why the responsibility of detecting, if it's present, adult ADHD falls on my shoulders, and I think on your shoulders as well. So that was step 1. What is step 2 now? This is step 2. If you start on a journey, for example, if I start on a journey to come to Helsinki, and I'm here in Texas, I certainly hope my pilot, before he or she takes off in Austin, Texas, already knows where to go, right? You don't start a journey without knowing where to go. Our journey, when we're encountering and trying to help a patient with adult ADHD, really needs to be very clear-cut. If we don't set clear goals, it's very confusing. All we're doing is prescribing medications and hoping for the best, or prescribing psychotherapy, hoping for the best, not quite knowing what am I trying to target. No, remember those 4? Remember that quartet? Symptom reduction, impairment reduction. There are 2 things I want to reduce and 2 things I want to improve. So it's a rule of 2 2s. Reduce 2 things. What are those? Symptom reduction, impairment reduction. I want to increase 2 things in every patient with ADHD: functionality and then quality of life. Please, let's not confuse functionality with quality of life. They are different constructs. Functionality is literally what it means: being able to perform in biopsychosocial avenues of life. Quality of life is what a person perceives as to the value of their life, as to their enjoyment of life, as to their connection with life. And adult ADHD is a big thief. It'll take away all 4 of them. So it's the clinician's responsibility to assess for those and help our patients with it. Now, you may remember this graph on the right-hand side. I showed it to you earlier. Do you remember? Maybe we can do a pop quiz right now. Do you remember, if you really, really, really want to improve a person's life participation, do you remember what percentage of symptoms must be reduced? Most likely you do. About 65% or higher. In other words, we have to be very demanding of ourselves and of our treatments. There must be large reductions, otherwise we don't get there. And one flows from the other. The more symptom reduction you have, greater the impairment reduction, greater the impairment reduction, greater the improvement in functionality, greater the improvement in functionality, greater the improvement in quality of life. It's a beautiful thing to watch the journey of a patient under our care when they walk in confused, no diagnosis, and they come see us, and we're able to accurately diagnose them, it's often a beautiful journey. To watch within weeks, just a few weeks, to see the light bulbs come on, to see them report, people now trust me, I trust myself. Life is better. I'm a better parent. I'm a better spouse. I'm a better friend. I have confidence. It's a beautiful journey, often. So treating adult ADHD is a passion for me. You can see why. So what do we address? We address all of them, but we have to start with symptoms. I cannot start talking about quality of life with a patient who's highly symptomatic. So I'm going to take you back, okay, if I may. See, there's a reason why I put 1, 2, 3, 4. We start with symptom reduction. We go to impairment reduction, functionality enhancement, quality of life enhancement. And we address it all. We have to. We want to. And if they have a comorbidity, such as an anxiety disorder or depression, we may have to address all of those. We may not have the option of just picking and choosing. Think about it for a second, will you? If a patient has hypertension and diabetes and migraine, which one do you treat? And the answer is yes. The 3 disorders. We have to address all of them. So we'll talk more about that in just a second. So please note, important point to remember, optimum symptom reduction is indeed the first step needed for short and long-term success. And please, in your mind, if you could, kind of cement this, not some symptom reduction. It's not okay, not with ADHD, not with any disorder for that matter. We're looking for about 60 to 70%. So if you want to split it in the middle, about 65%, or you might want to say 2/3 improvement from baseline. If those symptoms haven't improved that much, the odds are very high that functionality, quality of life will not be improving as much as possible.